So, guys, this is the 70th Pain Journal Club, and we are going to discuss this time the MSK Ultrasound and recent updates. So, thank you, Dr. Sasmit, for pointing this out. So, I will just make this full screen. So, before we begin, as is customary, we'll just have a short introduction. Pain medicine, actually, world over, has got diverse issues, variable standards, different learning requirements, different offerings. And of course, money and time is something which prevents different physicians from learning and entering this wonderful subject. However, Mumbai Pain School is an initiative of Panisha Spine Wellness and Pain Relief Center, Mumbai, to overcome these barriers. And most of our content is free, it is online and on demand. We have used social media to propagate knowledge, and we have been quite lucky and successful so far. So, we provide online learning, on demand videos, both free and paid content is available, as well as we conduct online workshops. We are very fortunate to have the support of expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. A journal club is nothing, it's just a club. The only difference being that we critically evaluate recent academic literature here, and which is based on a defined subject. Attendee participation is very important, so I encourage all of you to just participate to the maximum. Please feel free to ask questions, comments, give suggestions, and feedback. Uh, it is very tough to be regular. As I mentioned, each time we see new faces every time, which are different from the old ones. So try to be regular to maximize your learning. Even Harrison had his own journal club, which he used to conduct twice a month for critical evaluation of recent academic literature. Uh, Time and discipline is important, so I request these speakers to stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I practice in Mumbai as a pain physician. But today we have with us very esteemed faculties. I would like to introduce them now. We have with us a very senior pain physician from India, Dr. Neeraj Jain. He's one of the guys for whom I think the one slide doesn't do enough justice to his achievements. He's known all over the world for his exclusive talks and expertise in pain management. He's a senior consultant, interventional spine pain specialist working at various centers across Delhi NCR. He's a faculty for certified basic and advanced interventional pain management techniques international courses. He's pioneered non-surgical percutaneous fluoroscopic ultrasound or CT guided pain management, interventional procedures for spine disc disease, fracture of spine, cancer, or chronic pain disease. He's got a very large series of successful percutaneous needle discectomies with balloon neuroplasty, vertebroplasty, and kyphoplasty to his credit, including world record work of 6 level vertebroplasties. And he's actively participated and interacted with world leaders in pain management at various world congresses. So, welcome, Dr. Neeraj Jain, sir.
Thank you, dear Dr. Sidharth, and it's been pleasure to be with you and with MPS, especially with this academic mission which you're taking up. I'm so pleased, and you're doing a great job. I must compliment you, congratulate you for this. Must.
Thank you so much, sir. So, we move now to the second faculty. She's Dr. Namrata Bhagwat. She's done her MD fellowship in pain management as well as a diploma in nutrition and fitness. She's also an LLB, so a woman of many talents. She's consultant interventional pain physician at Vatsal Pain Clinic at Vatsal Hospital in Akola, Maharashtra. She's also liaison pain consultant at Sant Tukaram Cancer Hospital at Akola. Welcome, Dr. Namrata, as well. So now I will request the first speaker to just put up their CV slide. Dr. Kushbu, you can start sharing the screen now. Yes, I can see your screen. Can you make it full screen and put up your CV slide, please? Yep. Yes, the next one. Yes. So Dr. Khushbu Dubey is MD PDCC FIPM, that is Fellowship in Pain Management, and FPM MBA from IM Mumbai. So we have another woman of many hats. So she's currently a medical director and consultant at Shema Hospice Rehabilitation and Advanced Pain Management Center, Bangalore. She's also consultant pain specialist at Samprada Onco Wellness Hospital in Bangalore. So over to you, Dr. Khushbu.
Very good evening, all of you. The topic of today's journal is Update in Musculoskeletal Ultrasound Research, which is a clinical review of level of evidence 4. It is published in Sports Health Journal 2016 September by Kenichi Nawaka. The study was conducted in Department of Radiology and Imaging, Hospital of Special Surgery, New York, and Cornell University, New York. Introduction. Musculoskeletal ultrasound research is expanding due to its increased clinical utility of sonography. Ultrasound is widely applied in MSK imaging and sports medicine. Improved ultrasound imaging quality has allowed for its expanded use in diagnosis of musculoskeletal conditions. Combining the benefits of high resolution imaging, portability, and cost effectiveness, ultrasound is popularity in the evaluation of ligament, tendons, nerves, and extremities. Aims and objective. The primary aim of a journal is to provide comprehensive overview of musculoskeletal ultrasound, emphasizing the clinical applications, advancements, and research trends. The focus highlights the expanding role of musculoskeletal ultrasound driven by enhanced clinical utility of sonography. The objective is to cover the recent development in both conventional and novel ultrasound imaging techniques, and it offers a comprehensive and up-to-date resource for professionals and researchers interested in musculoskeletal ultrasound. Results and discussion. Conventional diagnostic ultrasound imaging is gaining popularity in evaluating ligament, tendons, and nerves in extremity due to its high resolution imaging, portability, and cost effectiveness. Challenges includes evaluating the MSK pathology in axial skeleton, particularly in deep abdominal or pelvic regions. Ultrasound is effective in detecting features like of orthopathy such as synovitis, bone formation, erosion, bursitis, and tendinopathy. Study validate the use of ultrasound in assessing disease response to treatment like methotrexate and biologic therapy in rheumatoid arthritis. This is a figure showing the sonographic evaluation of hip in a pediatric patient with right hip pain and with a clinical suspicion of juvenile inflammatory arthritis. The longitudinal ultrasound image of the right hip shows distension of joint capsule in this arrowhead with large effusion star marked in keeping with sinusitis, as compared to the longitudinal image of ultrasound of the left hip, which demonstrate a normal hip with a decompensated joint capsule. The neurosonology depicts of a figure. It usually has a characteristic appearance for nerves, useful in evaluating peripheral nerve pathology, including conditions like carpal tunnel syndrome and peripheral nerve entrapment. Limitation exists in deep lying neural structures, and technique is highly operator dependent with a steep learning curve. The figure demonstrates the sonographic evaluation of median nerve in a patient with hand numbness prior to distal plate fixation of radius. The transverse ultrasound image of this distal forearm reveals the hypoechoic scar tissue extending from the skin to the volar surface of the median nerve. In keeping with scar teething, the median nerve in the block arrow is abnormally enlarged and has a prominent internal fascicles consistent of neuritis. This figure demonstrates an ultrasound and MRI of right brachial plexus root in patient with upper extremity weakness after a motor vehicle accident. The ultrasound image of interscalene triangle shows a marked enlargement of SC5 nerve root with suspicious of traction injury, with MRI being more confirmative for the same patient, showing the abnormal enlargement of high signal C5 abnormal enlargement and a high signal C5 nerve root, thus confirming the injury. Muscle and tendon imaging. Grayscale ultrasound is useful in evaluating post-traumatic muscle conditions, fatty atrophy, and fibrosis of muscles. It is effective in assessing tendinopathy, tendon tears, and impingement, with its application in detecting muscle fasciculation in neuromuscular disorders. The potential is for evaluation of muscle injury and assessment of muscle health. It also helps to evaluate patient with glycogen storage disease, correlating muscle ultrasound density with muscle weakness, and also it is beneficial for imaging plantaris tendon involvement in mid Achilles tendinopathy. This is an image showing the transfer sonographic image of a forearm, sampling of muscle images showing in the block squares, demonstrating the different muscle echogenicity, with figure A showing the normal patient, the figure B showing myopathy, where we can see hyper echogenicity seen, and the figure C with patient with neuropathy. Things which to be noted is that the superficial cortex of radius is poorly visualized in patient with myopathy as compared to neuropathy and the normal sonographic image. So this is basically we can see that there are significant differences of sonographic appearance of muscle abnormality related to myopathy versus neuropathy. Also, this figure demonstrates sonographic assessment of ankle in a patient with medial sided pain. The ultrasound image demonstrated thickened and hypoechoic distal posterior tibial tendon surrounded with a complex tendon sheath effusion, keeping it with sinusitis. Novel ultrasound imaging technology. Fusion imaging combines real-time capability of ultrasound with anatomic detail of from CT or MRI, enhancing image-guided procedure. The CT/MRI fusion imaging mainly utilizes in biopsy, or mainly right now it is utilized in biopsy of hepatic lesions. However, in MSK imaging, benefits have been seen in image guided biopsy of bone lesions, biopsy of soft tissue masses, and evaluation of musculoskeletal injury. The fusion software can also be utilized in sacroiliac and facet joint injection. However, the benefits over fluoroscopy is to minimize the ionizing exposure, but more robust and clinical studies is required for its validation. Contrast enhancing ultrasound imaging explored for evaluating the tissue perfusion and inflammatory arthritis. The study, the clinical application of this study is to assess the perfusion pattern of soft tissue masses and the vascularity of repaired rotator cuff tendons, although the technical limitations and approval constraints exist. Microvascular imaging is a prototype technique for depicting microvascular flow in soft tissues, showing potential in MSK pathology. The clinical applications is used for evaluating the breast masses and thyroid and testicular issue, but there are potential applications of this technology in musculoskeletal pathology and tissue healing. However, there is no published studies that have been used SMI to evaluate the MSK conditions. Quantitative ultrasound imaging includes elastography, which is a quantitative ultrasound technique which evaluates the tissue stiffness, and it is applied in musculoskeletal imaging for tendon and muscle pathology. It has two major components, which include strain elastography and shear wave elastography. Strain elastography measures the relative strain of one region compared to another using the same stress. The stress applied is usually freehand transducer compression, and the output obtained is relative to strain map commonly color coded. Most of the literature of strain elastography for MSK focuses on tendon evaluation, particularly Achilles tendon. The improved diagnostic accuracy of it is also used for diagnosing the accuracy of carpal tunnel syndrome when grayscale ultrasound findings were used in conjunction with sonoelastography. In addition, spastic muscles have been characterized as abnormally stiff using strain elastography in spasticity disorder. Shear wave elastography measures the velocity of propagation of automated pulse through the tissue. The faster is the shear wave velocity, the stiffer is the tissue. There is a positive correlation between shear wave elastography tendon measurement and morphologic changes in grayscale ultrasound. Evidence suggests correlation between patellar tendon elasticity values and validated clinical scores for patellar tendinopathy. Shear wave elastography also offers potential advantage in detecting tissue changes not visible on regular grayscale ultrasound imaging. This figure shows shear wave elastography of patellar tendon, where the image A shows the grayscale ultrasound image with normal patellar tendon. Here in the arrow which can be seen corresponding to shear wave roadmap demonstrating expected dark blue signal in the tendon with corresponding to high elasticity measurement indicating the normal tendon. On the other way in the figure B, we can see the first image showing the ultrasound grayscale image with abnormal thickening of patellar tendon towards the proximal patellar attachment in keeping with tendinosis. The shear wave map demonstrate a heterogeneous yellow and light blue signal in patellar tendon of the same patients with elasticity measurement is decreased compared to that of a normal patellar tendon. Ultrasound guided interventions. It is highlighted as an ideal modality of image guided MSK interventions, and it has a very big role to play in sports medicine. The interventions include tendon fenestration, muscle tear injection, and perineal interventions. In tendinopathy interventions, procedures include tendon fenestration or prolotherapy, in which tendon fenestration or dry needling is used for the treatment of tendinopathy. The procedure disrupts the degenerated tendon fibers, including inflammation and promoting tendon healing. PRP injection, ultrasound sound guidance help in accuracy delivering the PRP to the affected area, promoting the tissue healing. This image shows ultrasound guide of common extensor tendon fenestration in patient with lateral epicondylitis. Ultrasound image at the lateral elbow demonstrate 25 gauge needle with a thickened extensor common tendon for the fenestration. Muscle intervention includes PRP for muscle injury. It is used for the treatment of acute muscle tears. Ultrasound guided PRP injection in acute muscle tear has one of the study demonstrate that the muscle tear has decreased the time to return to sports and higher level of pain relief in athletes, though the efficacy of this intervention is still under investigations. And also there is a lack of high quality of studies for PRP muscles injuries. Perineural interventions include perineural corticosteroid interventions, and it is utilized for accurate injection of corticosteroid through peripheral nerve to alleviate pain symptoms. The technique may prove injection accuracy and safety. Nerve hydrodissection involves injecting large volume of fluid around nerves to treat nerve entrapment syndromes. This can serve as an alternative to surgical decompression. Nerve root injection is has a potential offering an alternative to fluoroscopic guidance with added benefit to avoid ionizing radiation. The ultrasound image shows image guided hydrodissection of common peroneal nerve in a patient with radicular dorsal lateral leg and foot weakness. The transverse ultrasound image just proximal to fibular tendon show large volume of injectant uh, circumferentially dissecting away the tissue along with the common peroneal nerve. The longitudinal, at the same time, the figure B shows longitudinal image of a common peroneal nerve with superficial and deep surface of the nerve can be seen. To conclude, musculoskeletal ultrasound has significantly benefited physician in diagnosing MSK conditions. Conventional and novel ultrasound imaging techniques, quantitative ultrasound imaging, and ultrasound guided intervention continue to show promise. Future investigations are needed to determine the efficacy of these techniques in clinical practices. Limitations. Uh, there is limited evaluation of axial skeleton and particularly into deep areas within the abdomen and pelvis. Challenges in assessing diffuse pathology, since the technique proves to be more beneficial for focused clinical questions such as tendon tears, peripheral neuropathy, and ligament disruptions. There is highly operator dependency in neurosonology. The study of deep neural structure is highly operator dependent and had a steep learning curve. There are technical limitation to contrast enhancing ultrasound sonology. It shows promising in evaluating tissue perfusion, but it has a technical limitation. The timing of post injection imaging needs to be optimized, and intravenous injection makes examination no more fully invasive, non-invasive. The subjectivity in strain elastography provides qualitative measurements and its findings are highly subjective. There are limited evidence for PRP efficacy in muscle injuries, and safety concerns in ultrasound cervical root injections with there are potential serious complications including phrenic nerve palsy should be considered. There is limited visualization of lumbar spine nerve root under ultrasound. uh, the technique of ultrasound lumbar transformal injections are yet to be validated by clinical studies. There are limited clinical validation for novel imaging. Ultrasound tissue characterization and super microvascular imaging have shown promise, but the validation is yet to be established through larger and more robust studies. Variability of shear wave elastography measurements can be influenced by changes in transducer pressure and patient's positioning, contributing to output variability. Critical analysis. Quantification, because there is a limited discussion on quantitative validation and standardization of ultrasound findings is noted in the research. There is incomplete validation of novel ultrasound imaging technologies and intervention lacking the robust clinical studies. The study doesn't thoroughly address the generalizability of the finding across the diverse patient populations and conditions, and there is very low level of though the study demonstrate potential benefits, but the current level of evidence for it shows very low level of support for study findings. Lack of long-term outcome data in studies like prolotherapy, making it challenging to access the sustained efficacy. There is limited diversity in intervention. The study predominantly focus on tendinopathy and muscle intervention, lacking a comprehensive exploration of other musculoskeletal conditions and interventions. There is inadequate comparative analysis against the traditional methods, particularly in terms of efficacy and safety. While musculoskeletal ultrasound advancements show promise, but ethical consideration in these studies are lacking. Take home message. Musculoskeletal ultrasound is advancing with novel techniques and intervention. Ongoing research is focused on validating the efficacy of these techniques in clinical practice. Innovation in musculoskeletal ultrasounds are particularly highlighted in the field of sports medicine. And research emphasizes the promising future of musculoskeletal ultrasound for enhancing musculoskeletal health. Thank you for the patient listening.
Thank you, Dr. Khushbu, for the presentation. Now we go on to the second speaker,
But
Dr.
must compliment. It's a very well done job, Dr. Kushbu.
Thank you so
Compliment.
much, sir. And
Compliment. Very well.
I'm really happy that you are there for my moderation for this journal session, sir.
Pleasure. Always a
Happy to
pleasure. But you
meet
did a
you,
good
sir.
job. Good job.
Thank,
And there's a
thank you,
lot
sir.
of content, lot of carry message you get. Give only few of them, but there's a lot of carry message in your talk. Good job.
Thank you, sir. Thank you so much.
Great. So I think we take the questions in the end with the discussion as well. Now over to Dr. Sindhuja, who is going to share her screen. And after that, Sindhuja, please put up your CV slide so that I can introduce you. Okay, I have made you the co-host, so you may start to share your screen. Dr. Sindhuja is Vairamuthu is done her MBBS DNB anesthesiology. She is a current fellow in pain medicine at the DY Patil University School of Medicine at Nehru, Navi Mumbai. Over to you, Dr. Sindhuja.
Thank you, sir. Good evening, all. Today we'll be seeing about elastography in musculoskeletal imaging as a tool or a tool. So this study was done by P. Gracia Gonzalez et al. In the Hospital Universitario at Spain, and this was published in Radiology 2022 November December 64 edition. And the impact factor of this journal is 1.14. Introduction. Elastography is based on the principle of tissue distortion when force is applied to it. The more rigid it is, the more it will deform. This determines the degree of tissue hardness and can be used to detect changes in the tissue such as liver fibrosis. Tissues which deform less are considered hard or rigid, and those which deform more easily are considered soft. In the musculoskeletal system, it can be a complement to ultrasound for identifying the loss of tissue's normal elastic characteristics, enabling the detection of disease before it is visible by imaging techniques such as ultrasound or magnetic resonance imaging. Elasticity is determined by the elastic modulus of the tissue or ENS modulus, which is measured in kilopascals. The ratio between the force applied and deformity obtained is ENS modulus. The information is obtained before and after the force is applied, and depending on the technique, qualitative information as a color map or quantitative information with numerical values is obtained. There are two types of elastography, which is strain elastography and a shear wave elastography. In strain elastography, the tissue is compact before and after a compressive force is applied. It is qualitative and is expressed on a color scale. The elastography can also be measured by applying an acoustic impulse emitted by a device in which both qualitative and quantitative information are obtained. In shear wave elastography, in which the speed of the transverse waves generated by the initial pulse is measured in meters per second, and according to the density, we obtain the elasticity in kilopascals. The aims and objectives of this journal is to study about the use of elastography in musculoskeletal system. The clinical applications of elastography are in tendons, muscle, ligaments and joints, and soft tissues. First, we'll see about the tendon. The healthy tendon is a very hard tissue. It will sometimes exceed the measurable stiffness limit under normal conditions. Elastographically, it is a rigid and homogeneous tissue. When the tendon is damaged, the transformations take place which lead to biomechanical changes. These changes can be identified by elastography, which can be useful in the early detection of tendon abnormalities. In degenerative processes, there will be a loss of normal stiffness, which can be recovered with reparative fibrosis. The most difficult problem in the tendon is essentially tendinopathy. Histologically, we see the breakdown of collagen with increased cellularity, the development of new vessels and fatty infiltration. When advanced and tendinous degeneration is evident, it is called tendinosis. Ultimately, these changes can lead to tendon tears. So this is an image showing an Achilles tendon repair, which has the suture material in situ. And after the repair, when elastography was done, you can see this orange-red portion, which shows that the stiffness of the tendon is retained. So this is given here. The post-surgical changes with the suture thread. The shear wave elastography shows that the tendon is
Dr.
retained.
Sindhuja, can you please use your arrow to demonstrate and
I'm
show
using it, sir. Can you see it?
Not really. Can you move it to laser pointer then?
Yes, sir. Right.
Can you? Yeah. Okay.
Now, okay. So this is a Achilles tendon which has been operated. This is a post-surgical case, and hence we have a suture material in situ. And after the surgery, when elastography was done, you can see the tendon has regained its normal stiffness, which is shown as an orange-red area. So this is the next picture of a patellar tendinopathy. Here we can see the hypoechoic structures and heterogeneous mass of the patellar tendon. It's just in relation to the tendinopathy. The shear wave elastography shows a clear predominance of the red hard area, indicating it still maintains its stiffness. However, we can also see some blue lesions. It's a blue-green soft tones can be seen, suggesting tendinosis. And after that, when Doppler is done, it shows that there is some new vessel formation in here, which also suggests that there is tendinosis. So this is also an example which shows that there is a distal biceps tendinopathy. This tendon shows an engrossment and marked hypoechogenicity consistent with tendinopathy. However, given its depth, it is difficult to determine whether there is a tear foci or not. In elastography, this shows a red area in insertion area, which is a soft and strain indicating an intrasubstance tear. And this is another example which shows a hamstring fibular tear. Here is a hamstring fibular tear which is less than 1 centimeter, which is adjacent to the conjoint tendon. So in elastography, you can also see a red point here, which also indicates that there is an intrasubstance tear. Epicondyles, both medial and lateral epicondylitis are thought to be caused by repetitive microtraumas that causes microtears, which in terms of elastography translate into foci of loss of stiffness. So in epicondylitis, we have an example of this picture where there is a small tear in the extensor tendon, and after the tear is identified in ultrasound, the patient has undergone a PRP therapy, and after 3 sittings of PRP therapy, 10 days apart, the EOJ shows a homogeneous structure of the tendon, and on the shear wave elastography, we can see that orangish portion of the tendon, which shows that the tendon has regained its normal structure. Rotator cuff, the curved trajectory of the tendon and the fact that it is in contact with the bone makes assessment by elastography difficult. However, a good inter and intra-observer variation correlation has been reported. The loss of rigidity essentially allows intratendinous microtears to be detected. Muscle, the elastography helps in the dynamic assessment of the muscle stiffness during movement to detect abnormalities before they are visible with conventional imaging techniques. The elastography has a role in the assessment of muscle spasticity, such as stroke, spinal cord injury, myopathies, etc., muscle tears, and myofascial pain. In muscle, the muscle is remarkably heterogeneous because this is the structure of a muscle, which shows a muscle fiber which is surrounded by an endomysium, and these all form into a fascicle, which is surrounded by an perimysium, and the perimysium in turn is surrounded by the epimysium, which is interspersed with the nerves and vessels, and this is the reason for the heterogeneous structure of a muscle. So the elasticity is also influenced by the type of muscle, location, individual characteristics, and as with tendons, measurements vary depending on whether they are made in the short or the long axis. So in elastography, some myopathy shows decreased stiffnesses, whereas in some myopathies like Duchenne, as well as in spastic stage, there is an increased stiffness. This increased stiffness has also been described as idiopathic muscle pain or cramp, which is delayed onset muscle soreness. The loss of stiffness is seen in case of muscle tear. So the elastography helps in assessing both tissue repair and its possible complications such as soft scar. Ligaments and joints. Ligament tear will be detectable as soft areas within the normally stiff ligament. Elastography has also been used in the study of rheumatic diseases to assess the synovium. Soft tissue masses, benign or malignant, based on its stiffness. A soft lesion is more likely to be benign than a hard one. It also depends on other factors such as bioelastic characteristics of the tissue and the location of the mass. Results and discussion. There is a 10-point recommendation on how to use an elastography. It is obtain a good image in beam mode, apply the least possible pressure with the transducer, position the transducer perpendicular to the skin surface, keep motion artifacts to a minimum, wait for the elastogram to stabilize, use the appropriate preset for the medium, place longitudinally to the structure. So, over anisotropy. And given the heterogeneity and lack of reference values, it is preferable to be guided by the color maps. When making measurements, it is preferable to measure speed as elasticity is obtained by multiplying it by density. Use it whenever possible, correlating it with the beam mode and with the signs and symptoms to improve the technique and to progressively establish the reference values. So finally, as an elastogram as a tool or tool, it is up to us to use the technique rigorously and seriously, establishing indications and protocols, applying it as a real tool, as a complement to ultrasound, instead of as a mere decoration for an ultrasound studies. Conclusion, elastography is a greatest technical advance in ultrasound since the Doppler. The technique is still in the research phase, primarily in musculoskeletal image. It will be essential in the early diagnosis, prognosis, monitoring of treatment, and follow-up. And it has yet to become a routine part of our day-to-day work and for indications and protocols that it determines the tool to be established. Limitations accepted are elastography has the same limitations as ultrasound, such as operator dependency. For example, placement of a transducer, avoiding clear pressure, choosing the target area. In addition to its physical limitations such as gas, calcium, and obesity, there are also other limitations based on the tissue being studied, with its heterogeneity and anatomical variability, making it difficult to create reference values and establish protocols. Critical analysis. There is a limited discussion on current challenges. There is no mention of comparative techniques, and there is a lack of specific example, and the indications and protocols need to be established. Take-home message: elastography as a novel imaging technique based on ultrasound holds significant promise in musculoskeletal radiology. Elastography is a powerful weapon for early diagnosis, prognosis, treatment monitoring, and lesion follow-up, with the potential to become another complementary tool. Thank you.
Thank you, Dr. Sindhuja, for the excellent presentation on elastography. So over to you, Dr. Neeraj Jain, sir. I think I can't see Dr. Namrata yet, so you'll need to conduct the proceedings further.
It's okay. It's a pleasure. It's a pleasure. Well done, both of you. By the way, Dr. Sandhuja, you were a little fast-tracked on your talk, and we had a lot of time, by the way. Because why I'm saying so is it's one of those very, very new thing, very novel thing, which needs a lot of, attention and a lot of learning, because it's new to the people. So it needs little, you can have gone a little slow. Because I've gone through the paper, so I know what you're talking. But the people who are just new, who are listening it first time, for them it will be a little fast tracked. But there's a lot of promise of this new technique which has come up, elastography, and especially in the MSK and all those things which is coming up. In fact, it's new for us too. People who are experienced in ultrasound in day to day in MSK and other applications, for them also is new. I'll tell you the reason why. These all are elastography with the high-end machines. We have seen this used with the liver stuff and other diagnostic modalities only in the diagnostic ultrasound, which is in the radiology department. They don't really come to the point of care ultrasound, which we have in our theaters lately. So there is a limitation of using elastography for our day-to-day practice, especially in MSK. Yes, it has got a diagnostic utility. Again, then we have to depend on the radiologist for that. But as we are learning, as you are learning, I must compliment you for this. And you took a very good job on the detailing of the topic and subject. So there's a lot of learning on part of the even senior people. See, you young people, you adapt very fast. But again, it's a lot of learning for me. Like I must compliment Dr. Sidharth when he took up this topic of elastography, because elastography is really not all that wider application in the MSK in Indian scenario, at least because of the cost deterrence. The cost of the machine, which has got a right elastography, is about 50 lakh to 70 lakh rupees. So we don't expect a point of care ultrasound machine in our theater with that cost. Frankly, that's the problem. And unless you really have a good machine in your OT and where you have the elastography which you're making use of. I don't know whether Siddharth, you have anyone in the theater setting. Frankly, I am not sure of, not in my knowledge. But yes, it's a good learning thing. One has to learn beforehand. One has to, and obviously, when you learn it, you're going to apply it sooner or later. So I'm happy that you took up this topic, both of you, and even Dr. Siddharth, I must compliment. That's a beautiful topic, elastography, and it's learning for us also. When you have a challenge coming, that okay, it's elastography, like for me. Okay, let's see, let's read it. And you find such a amount of potential with these things. We've been seeing decorated images in our, liver elastography very often, and that's okay. But coming to MSK, yes, means I'm truly impressed with the amount of potential which it has got. And you see, the Westerners will always pick it faster. They are resource quite resource that way. We have resource deprived, so we have a problem with that. But those people are really doing better. But I don't get surprised that with the high end centers, they will get us a elastography machines sooner or later in our MSK setting, or we can do a diagnostic MSK in their centers like radiology suites, and then starting making use of that. Another thing which is vital, which you said in the beginning of Khushbu, that there's validation is poor. No, ultrasound in
Yes, sir.
MSK is quite validated by now in lot many potential places. Like we talk all about joints and peripheral nerves, there's no better tool than the ultrasound machines for your diagnostic as well as for interventions. This surpasses
Just
diagnostic value even in some peripheries, like carpal tunnel syndrome and other diseases, like even in shoulder pathologies, because getting an MRI, a repeat MRI or repeat studies is difficult for a sequential, seeing the improvement or response to therapy or response to your conservative management or your interventions. So this is a good tool. Once we get an MRI with us, and thereafter you can follow up with the sequential ultrasound. So this is a very, very helpful tool. and it's quite well validated, by the way. So that way, we don't have to look for any more validation for few places for ultrasound. And I tell you, if you pick an ultrasound probe in your hand and start working on it, you will fall in love. All of you pain specialists who are hearing and who are there, especially the future people, young people, you'll fall in love with this tool and you really love it. Means I've been doing procedures like shoulder, knee, and other places for ages with the fluoro guided and all. But I feel I was wrong now, once I retrospect. So that feeling has cropped into us. That is why I keep pushing people, use ultrasound as much as possible. Try to put hands on, see, and you can do a parallel thing like combine fluoro and ultrasound thing. But you will find that sooner your fluoro unit will be defunct, because you're doing so much of good work in ultrasound. So that's my call. Good work, good talk, and good topic also.
Sir, I was just mentioning regarding the clinical validation of novel ultrasound imaging, the not the routine grayscale, the whichever has come in a novel new additions to our grayscale imagining. In that imaging, I think validation is still not
I
being
know.
done.
So we see when
Yeah,
something new comes, it always takes its own time to
some
establish
time to
itself. So
establish.
that phase will be there. That phase of initial phase will be there, incubation period where it really validates itself, and people are started using. It's only then people put hands on those instruments and these. Like very frankly, in India, we don't have those elastography in MSK. So
Yes,
how can we validate on
validate.
that? It's only we have to wait from the Westerners who are having MSK elastography machines with them. So obviously we lack on that. That's validation so poor. That's a wider the application is there, more is the data there, and then more robust is the studies, by the way, and then you have validation coming. Obviously, that is the reason the validation has been poor as of now, even for them, by the way. When we talk ourselves, because we are limited with the machine part, but they have the machines are given, then they are not using it that often because there is a comfort zone with the routine ultrasound. We have been doing it 2D, 3D, whatsoever we're doing it. We are comforted with that, so we're not getting into this elasto. But looking at the validation of few works, when they say Achilles tendinopathy or pedal tendinopathy or even the lateral epicondylitis or all those things, they found that this is a better tool than 2D and other studies. So that way, over a period of time, people will fall in place. This happens, always happens. So that way, we've been doing blind work for centuries. I've been saying. Now we're doing all fluoro guided work for last few decades. The ultrasound is there for last decade or so with us, and it's going to improve upon. We should be prepared for it because life is more precious than any tool for that matter. So I would rather say, let's go, let's take it up, let's know the facts first, and then tool will follow. The tool will come.
Sir, one more question for you is like I want to know actually, sir, how is your response with image guided interventions for muscle PRP, sir? Because some of the study has shown good results. So if you have done, sir, what can you just enlighten us with your experience, sir?
Frankly, muscle PRP is only when we have to do for the muscle injuries.
Yes,
When
I'm
you said the
saying
word
muscle
muscle injury,
PRP.
you do PRP. First thing you do in muscle PRP, muscle injury is your diagnostic imaging and you find an hematoma. The first is to manage that hematoma. That's the first point, which was not been talked,
Yeah, in the article it is
yeah, in the article. So the hematoma has to be tackled first. Then comes the tear. Now you have to create a space, or there's a fluid. Like sometimes there's a tear shoulder supraspinatus or epicondyle, epicondylitis, there is a tear, and you find there is tear or Achilles tendon, there's tear. You have to evacuate those tears, empty those tears to create a space for your PRP. You cannot inject PRP unless you made a space for the PRP. So as a rule, first make a space and then put PRP. As if you keep putting PRP right over the hematoma or right over the fluid which is already accumulated, you are creating another tear or increasing the tear. So as a rule, this is must for all those things to be evacuated first before you put another thing. So it has got a role. Means I will never ever do anything. Like obviously, I should tell you very frankly, when you say the ultrasound, you got to see the lesion. You got to see the place you want to work. You cannot be blind about things. And obviously, PRP is a costly affair in the sense that it is patient's own blood, and you have about 5 ml of stuff only. If you keep putting in a normal muscle or normal place, be it any part of the body, you're wasting that precious PRP and where it is really not required. Another use which I find with ultrasound, which I must mention here, is that it changes the landscape in the sense we've been doing the shoulder and other injections with like 40 or 80 milligram of depometrol. And we were injecting and we were supposing that you're doing a good job. Of the 40, 80, only 1/5 was going at the spot where it had to be. So we are wasting the other 4/5 or 9/10 on the places where it is not really required. And obviously steroid is steroid. And when it's not the right place, it is harmful. Like if you inject steroid in a muscle, it's a harmful scenario. So we've done those blind works in those times, and we have been, forgiven by God. Say I call it as a time now. So do all this ultrasound guided. You can manage same work, same effect, almost 1/4 or 1/10 of the dose, and obviously, and without problem of the cortisone toxicity, we got the steroid toxicity, which tends to come otherwise. So that utility of ultrasound is there. Never ever miss it. And most importantly, the ecstasy or the pleasure of seeing the subdeltoid bursa, like you're doing it. Obviously, you're seeing the bursa. You're emptying the bursa and you're putting a drug in. So that or any other place, we have a fusion, knee fusion. You're emptying the fusion first before you do any injection inside. Be it PRP, be it anything. Or you have other regenerative solutions or methods. But that envisioning is most vital, I must say, than any blind procedure. So any place peripheral in the body, even cervical areas, it has really taken over all other imaging modalities, especially when it comes to therapeutic interventions. I'm not talking diagnostic only. When I'm talking, and you have the benefit of the tool, it is both diagnostic and therapeutic in a one go. So you can have a look at it and you can do the needful. So that's the beauty of it. Dr. Any your thoughts, your inputs?
No, I think I agree, sir. Only a couple of things. One is, sir, we have the regular machines now with which have come up with the elastography modules. Like this module can be activated on the regular GE Logic Q, which I think costs around in 20-25 lakh range. And uh, however, it will still be very cumbersome as it's a big model, and to take, as you rightly said, from one place to the other. And of course, we can take a cue from liver elastography, which is a more established kind of technique, which is being used for a longer period. And another thing to spark the interest, the why I chose this paper was to just spark the interest for probably for future, opening the future possibilities um in this field. And also, an interventionist will be more interested in this data rather than a diagnostic person. So maybe somebody who is doing it for a diagnosis will not have that much of value. But if you are seeing a Doppler, like Dr. Sindhuja or somebody showed in their paper, that when they are using a Doppler, they are not seeing anything initially, but when they are putting the elastography mode on, and then that time they are pointing out to the blue areas, and then they are scanning the blue area nicely, and then they are seeing probably some structure. So it can be just one more uh, method which can be used. That's the minimum which we are looking at. And to my surprise, when and I have put up the paper in the chat also, that there is a MR elastography as well. And for elastography to be done, you don't need to put pressure yourself, because the pressures, there are pressure waves which can be generated, and there are also these drivers which generate the pressure waves, as probably in an MRI, because MRI, it requires you to be static. They say "Arey hilna nahi." So and you are talking about elastography in MRI. So definitely, I think if some of the clinicians, many of researchers are must be here, they can just collaborate with the possibly with people who are doing elastography, probably for liver. They can come up with something which is useful in the MSK field as well. And of course, as you mentioned, Western people, they are much more resourced, and the much more luckier than us, because they work in a setting where usually the money is not a constraint. I mean, we work usually in the other way around. So most of the researchers, they they can just think of something like this and maybe utilize some grants or something to just kind of collaborate and find something. Until then, it is going to be just a topic of academic interest till, of course, we can be sure and apply this to our working. But when I think of your personal story, sir, when you started doing using all that balloons which you use and all that, so now this was also ahead of time. So probably similarly, what we are doing and discussing today, it's ahead of time. But when we see in retrospect after some time, this should look like a very logical next step to add something. It is the single biggest thing in ultrasound after Doppler. That is what is elastography to us.
That's true. No, they're already talking about the MRI ultrasound fusion and CT ultrasound fusion, and just keeping over the images scans over each other and start reducing on the ionized radiation next time when you do a follow-up procedures and all. They're already talking about it. Just like navigation systems, they do all the spine work in navigation to reduce the radiation. So probably, but it's good to know. See, knowledge is always is a utility. It never goes waste, and we're talking something which is coming. So we should be well prepared for something, especially younger generation, for something which is coming. You cannot escape. Like when revolution came, like pagers came, then mobile came, and then every new model comes with the smarter phone and everything. So people adapt. So you should be well prepared to grasp the latest. And I do see a lot of, as I said initially, a lot of potential with this thing. And remember, when new technology comes, there's going to be a development as an advancement in the new technologies also. So we have to grasp the basic part of it first, then we'll take up the advanced part of it also, which is going to come in any case. So we should be well prepared to grab it, catch it, and use it. It's not that you know it only, you have to make use of it. That's a clinical scenario, clinical part of it. So vital that you learn out of this, make use of this, know the nuances of it, and that's what is really required for all of you. But remember, ultrasound is a beautiful tool. I used to say that maybe a decade earlier nobody is doing a pain until unless you have a CM and RM machine. Maybe just watch it in down the line. Nobody will be a real pain specialist until unless you have ultrasound in your theater. That is going to be the scenario. Please don't mind if I'm getting a little harsh on that, but that's the fact of the matter. Ultrasound will be the main tool in our pain suites or pain procedures, because it's such a beautiful tool for all extremity procedures, even for cervical procedures, even for like in lumbar procedure lately, like we do a piriformis and all those procedures, and even assign caudal. Probably this is one of the best tool. And you got to, by the way, we have gone through, I have myself taken about 3-4 lakh of those shots, CM shots. Lucky I'm still surviving. But what about these young people? They have all life ahead. We started age of 45. Okay, let's suppose. But you're starting age of 25. So you have to another 20 years of radiation on you. So please avoid those radiations. Adapt to the ultrasound as soon as possible. Stay away from CM to avoid the radiation. If you can manage best with the ultrasound, which is the game, which is the rule as of me. So I'm really going away from the CM, not for the radiation reason, because ultrasound is a better tool. That's the reason I'm trying to bring. You can do a fusion work initially, combined fluoro ultrasound, and then obviously you will slowly will switch on to the ultrasound only. But definitely the CM has got its own place. It will never go away, obviously for many good reasons and many good procedures also. But yes, you have to do a judicious use of both the tools which are there in your hand. And elastography is coming as another add-on, not only decorative but utility tool. It'll come in your own pace and very soon. As Dr. Sidharth is saying, they have got in their machines. Good, I'm happy to hear that. But normally it's for those high-end machines which is starting from 50 plus to be a good elastography machine, because elastography has got a different software and hardware together, even hardware together, and that makes it cumbersome. And what you said is people are doing through the external ESWL and all, but that's again another add-on feature, so we don't have to get onto that. Yes, definitely, this is vital too.
Great, sir. So Dr. Sindhuja, Dr. Khushbu, if you want to add anything, otherwise we'll just uh, go to the next part.
Sir, one
Anybody, any
one thing
questions,
which I
anything? Mm-hmm.
One thing which I wanted to add for the strain elastography is that one of the study has shown good correlation between the strain elastography and histologic evaluation of tendinosis, and also it has a good role in evaluating the clinical markers of tendon pain and dysfunction. So this is something which I wanted to add because I have missed that point in my presentation. I thought if I get some 5 minutes, I will just mention this as well.
Good.
Great.
By the way, your talk was as it is very contentful
Thank you
and
so much.
very well received also. But I've just when you say this, because many people are doing it as an evaluation diagnostic and as well as a follow up, studies. When you do the follow up thing and they want to check, when the surgery is done post surgically, how is the difference between the pre and post. So those all are there. Quantitative and qualitative studies are there. So they become very, very quite vital that way. It's important. It's important.
Thank you, sir. Thank you so much, sir. Thank you.
Yeah, Dr. Sindhuja, any comments from you? Otherwise, we'll just move on. No. Okay. Okay, great. So thank you, Dr. Sindhuja and Dr. Khushbu for the excellent presentations. And thank you, Dr. Neeraj Jain, sir, for supporting us as always. And your
My
valuable
pleasure.
contributions are always, very exciting to hear and see and learn from you.
My compliments again, Dr. Siddharth. Very good topic and very rightly timed for young generation to understand how good there is a tool coming, which is so important and so, what do you call important? Learn in right time. So this is a very timed article. Beautiful.
thank you, sir.
Thank you so
So
much, sir.
thank you, all of you. So let's move on to the next part. This is the season 4 of the Mumbai Pain Schools Pain Journal Club. And in this season, we have focused on MSK Ultrasound. Uh, so we have got a new time that is 8 p.m. and we have got group topics with 2 faculties, 2 papers. And of course, the next steps would be to join our mailing list. The link is in the WhatsApp, in the chat. The WhatsApp link is in the chat, which I have put it already. And any suggestions, comments, suggestions, queries are welcome. Just mail it to mumbaipaintschool@gmail.com and I will personally, answer that. And see you all next Friday at 8 p.m. Thank you for joining, and we'll meet up next week. Bye bye.
Bye. Bye, dear. Well done. Well done. All of you.
Thank you, sir. Good night.
Bye. Good night. Well done, Sandhya. Well done,
Thank
dear.
you, sir.
Well done. Bye-bye.